You're listening to Parents You've Got This, the expert guide to parenthood. Your complete guide to pregnancy, birth, baby and parenting. Join us for the journey.
We all know that pain is inevitable for birth, but I think there's a lot of confusion around the different options available. We're very excited that today we welcome back our regular guest, Dr. Peter Jurcevic, to talk all about pain options and implications for both mother and baby.
Thank you so much for joining us again today, Pete. Dr. Peter is an obstetrician and gynaecologist with more than 27 years of experience. He specialises in high-risk obstetrics and he works in both public and private practice in Melbourne. He is also an Australian pioneer of the maternally assisted caesarean, so he is absolutely amazing. He's delivered more than 6,500 babies and we are really, really fortunate to have him talking with us today.
Thank you for having me.
Thanks for being here, Pete. So, the all-important topic of pain medication. Can you talk us through, please, what some of the options are for pain meds and then what the implications are for mother and baby and the implications it can have on the birth outcome?
Sure. So, as you alluded to at the beginning, there is an inevitability to labour if you're going to birth and have an attempt at a natural birth, vaginal delivery. And that's just going to be contractions. And for most women, they'll be experienced as pain of varying severity, varying frequency, varying duration. I think one of the key parts to the talk is really focusing away from medication initially and focusing on education and focusing on some of the natural options available, and education being one of the key words. I was very blessed having trained as an obstetrician and delivering babies. My job was very reactive. So it was all about reacting to pain, reacting to delivery assistance issues, problems that might occur during birth, but not much that was in relation to the preparative process. And then I watched my partner go through her first pregnancy, our first pregnancy, and she was very fearful of pain relief, and in particular epidural, and her biggest fear was the thought of someone putting a needle in her back. Very fearful of that idea, irrespective of whether she might need it. So she took it upon herself to investigate options, and she came across Lamaze, calm birthing, hypnobirthing practices, and this active birthing practice is where you're educated to learn how to breathe and relax, and in some respects it's almost like a yoga meditative way of training your mind and your body and your breathing, so that when you're getting the contractions or surges or whatever terminology you use, you can manage that pain. And you go to a class and you are taught the skills and then you practice. And dare I say, practice is important in any aspect of life. You know, we practice, we train for sporting events, we study for exams. We're always doing things in preparation. When you're trying to push a baby out of your body and go through the pain associated, you need to train for that. So there's very good data sets, good statistical scientific evidence as this helps. So education, birth education, Lamaze breathing, crucial. It takes a lot of the fear out as well. Okay. Now, when you're at home in the early phases of an evolving labour, and let's assume it's your first labour and there's an evolution of pain that might come every half an hour, every 15 minutes, every 20 minutes, maybe incoordinate, maybe more coordinate, but nonetheless it's getting sore, you've got to start thinking about your strategies. Now, your strategies may be something as simple as just using those breathing techniques. And when I say as simple as, complex taught skills that you'll learn. Some women will use their bath or shower, and water therapy has been very effective for a lot of women in helping to manage pain, just that soothing capacity, the buoyancy, the tactile stimulation, a combination of all those things. There are some women who have investigated and have already bought or borrowed a TENS machine. This is a little electrode that uses electrical current battery generated, and the little strips are placed on your lower back, and it's diagram advice, so your partner can do it for you. And as you get a contraction, you press the button and it sends a little low voltage amount of electricity into your lower back. And what it does is it tries to trick your pain fibres. So it tries to trick them into not feeling the pain that's going around into your abdomen. And all of these solutions you can do or options rather, you can do at home. Okay. Obviously positions you're in, your partner speaking with you, the birth affirmations you're listening to, local massage, like tactile points, your partner might have been taught some skills, all options. There'll come a point for most women that they're going to want to birth in a hospital. I do say there will be a few that won't, but most are nowadays. And so when you come to hospital, coming to hospital doesn't mean you have to be medicalised, it just means you're coming to hospital. And usually you're coming because the pain and the contractions and the labour is intensified, and so you want to birth at the hospital. Okay. Now, for someone when they come in, they are still using those techniques, and the hospital will support the ongoing use of those techniques. You're breathing, using the TENS, using the water therapy. Obviously, you can't do the water therapy and the TENS at the same time, being a small voltage current associated with it. There'll come a point though where if those solutions aren't helping you, then we start to look at medication. Okay, so medication ironically can be gas. Gas is ironically, I guess, technically medication. What it is it's nitrous oxide, and it's basically mixed at a percentage with air or oxygen. And you can inhale this, and as you inhale it, you'll hear a little rattling noise to indicate you're inhaling properly. And when you inhale it during the course of a contraction, it can provide you with a slight sedative or analgesic effect. For some women, it's very effective, and that's all they'll need to do on top of what they've done. Some women might feel a bit nauseated from it, some women will be very spaced out from it, and some women it won't touch the sides. But it's an option, and it's there to use if you wish to, and the midwives in labour ward would guide you to that. We are happy to offer an injection of morphine. In previous years, pethidine was used, morphine more so nowadays. Ironically, believe it or not, many, many years ago, we used to use medical grade heroin in labour because of its narcotic analgesic effect. But a dose of morphine to the right person at the right time can be a circuit breaker. So if you're starting to lose a bit of control, it might just take the edge off the intensity of the pain you're having with each of those contractions.
Does it affect the baby, morphine?
So in very, very rare situations, if you have a timed dose of morphine and say within a short time frame, for argument's sake within an hour you deliver, a very small percentage of babies can get a narcotic effect, so what we call narcotized. They come out a little bit stunned. And if we can see that that baby is coming out stunned, not just because some babies do come out a bit stunned, their blood pressure's a bit low, their partial pressure of oxygen's low, they just need a moment to get themselves going. This is a bit of a sort of a morphine stun. We can either razz the baby up appropriately for you, or we can also give a little bit of reversing agent. So what we would give to a drug overdose patient, believe it or not. And it's amazing sometimes in the very rare situation where that's needed, how the baby is lying there and it just wakes up and it starts crying straight away. So fear not, it's a very low risk option and safe to give. There are of course going to be a percentage of women, and interestingly, certainly with current data, about 40% of first time mums who labour and try to have a baby will request an epidural. And I don't blame women for making that choice. An epidural has the advantage that once it goes in almost every case, you will be numb from the waist down. You will be pain free. And the way that it's administered in a little catheter that's placed at the time of insertion means we can keep topping up the dose and administering yourself with a little button that you will be advised on how to use and press. So you can keep the dose in your back topped up, so you'll be numb all the way until you deliver, because you might get that epidural 2 hours to go, or you might get that epidural 13 hours to go, and so it needs to work the whole time. Now, epidurals almost always work and work well, and will give you great pain relief. But what we need to understand is that there are physiological consequences to epidurals. So when the epidural goes in, not only does it make it that you have no pain, but all the sensations that you lose mean that you might not know when you're fully and when you're ready to push. And it might be hard to push because you don't have any sensory feedback. Because it alters some of your local physiology, your blood pressure can drop. If your blood pressure drops, you might not feel well with that. Sometimes the baby might not like that, and we might see that on monitoring. And because we're also changing some of the local physiology, it can change, I guess, the physiology to the uterus. So the uterus may not work as well, may not contract as well. And so sometimes we might have to help assist contractions. Now, this is not every single case, but one of the things I usually say as a rough guide to women is that please have an epidural if you need it, but please think about the 5 options I've just given you. Mm-hmm. Breathing, water, TENS, gas, morphine. And then when that all is been exhausted, have the epidural. But just understand, if you have the epidural, it's going to potentially alter the birthing outcome. So we know probably from a statistical perspective that for women having an epidural, it probably doubles your chances of intervention down the course of your labour. Needing waters broken when maybe they didn't need to be. Needing a drip for medication, contraction support, maybe you didn't need that. Needing help to assist the birth because you couldn't push the baby out yourself. Fetal distress leading to seizure. So you are upping the chances of consequences to the birth. Now, a lot of people listening now will probably say, well, I better not have an epidural. And of course, I would say, yeah, try not to. But you need to understand there will be a point for 40% of women, we know this, where the pain will just be too unbearable. And so if you need the epidural, don't feel dismayed, accept that you need it, and trust that hopefully the birth process will still be okay. And we can help support you if there are challenges during the course of the birth when the epidural's in.
And is there a point where it's too late to have an epidural, or can you have a birth plan? I know you've said that you want to try all of these things, but what if you're petrified of pain and so you just think, okay, I just want the epidural as soon as I come in?
I think for me, particularly as a male doctor, to look a woman in the eye and say you can't have pain relief would just be ridiculous. Every woman is entitled to pain relief. I think I just point out what I've just told you, the statistics, the awareness of the other options, the vital importance of preparation and birth education and Lamaze and so on. But I think at the end of the day, if an epidural is required or you just want to have that, that's totally fine, that's your choice, as long as you understand the old notion of informed consent, what the consequences may be. Okay, and then of course if you have that epidural, then you accept that those consequences will come with it. There is this notion of, what if you say, Peter, I can't have an epidural? Now, to look a woman in the eye and say you can't have an epidural, a lot of viewers would think, well, that's quite barbaric, and how dare you, as the male doctor, say no to a woman's pain relief. When I say no to a woman for an epidural, I'm saying that because I am near certain she's going to have a baby very soon. So I'm near certain by the time the anaesthetist comes in, puts a drip in, consents her, puts the epidural in, and then it works, she's probably going to be fully in pushing the baby out. And unless I miss the boat, the best way to have good pain relief is to not be in labour. You push a baby out, the pain stops straight away. So if I'm confident you're about to have the baby, and I'm really confident in the way I can work with you, and the midwife will work with you to get your psychology right so you're losing control, but we get you back online so you can start pushing well, and you push the baby out, and I'm confident you'll do that, that's better than having an epidural. So when I say no, I would like to think people I look after, their brain would go, great, that's Pete telling me I'm about to have my baby.
And so it's not instant getting an epidural. There's a time lag between asking for one and having one. How long is that time?
So look, be it in the public or the private sector, based on how busy the labour wards are, how many women have already requested epidural, how many staff there are to administer the epidural, time of the day, at night, if you're in a hospital and the anaesthetist might have to drive in. So there can be a time delay associated with this, depending on where you birth and how you birth and so on. But we would like to say that you'll be able to get the epidural in a timely fashion. And also we can support you in that time from your request until when the epidural is administered and works.
Fantastic, Pete. Thank you so much, and thank you for talking us through it in such a staged approach too, where we know that you really recommend and believe in those early non-medical options for dealing with pain relief first before you move through the different medicinal options that are available. So thank you very much for sharing your wisdom on the podcast today. We'd like to say a special thanks to Mostella for sponsoring this episode.
Next week on the podcast, we'll have Dr. Peter Jurcevic back again to talk to us all about medical inductions and assisted deliveries. You've been listening to the Expert Guide to Parenthood podcast, and never forget, parents, you've got this.
You've been listening to Parents, You've Got This, the Expert Guide to Parenthood. You've got this parenting gig